Well, hello everyone, and welcome to another live event brought to you by ChiroSecure. We have a really great show for you today. We're so excited. Remember, ChiroSecure's live events educate and support you, the practitioner, by making sure you have the information you need to protect you, your practice, and your future. Today we have a great guest, Dr. Gerry Clum. Everyone probably knows who Dr. Gerry is, but today's topic is an update on cervical spine adjusting and vertebral artery issues. Let me tell you a little something about Dr. Clum, if you don't already know this. He's a 1973 Palmer graduate. He's a faculty member of the Palmer College of Chiropractic. He's a founding faculty member at Life Chiropractic College, first president of Life Chiropractic College West, board of directors or officer of the Association of Chiropractic Colleges, the CCE, the ICA, the Foundation for Chiropractic Progress, and the World Federation of Chiropractic. He's the immediate past president of the World Federation of Chiropractic. He was voted Chiropractor of the Year by ICA, Man of the Year by Dynamic Chiropractic, one of the top 5 leaders of the chiropractic profession in Dynamic Chiropractor's Readers Poll. What I'm going to do now is turn this over to the person who's responsible for all these live shows, right from ChiroSecure, Dr. Stu Hoffman. Dr. Stu?
Hey, thanks, Alan. Glad to bring you another one of our live shows, and today's a special one. Dr. Clum is somebody that helped me decide to become a chiropractor many moons ago and has been a mentor ever since. When it was time to create ChiroSecure as a program to bring into the profession, Dr. Clum was one of the members of our committee that helped create this program that we now have. And over the last 23 years, we've utilized Dr. Clum's expertise as an expert witness, still do. He is one of the leaders in the profession that helps me to learn more and more about certain issues when it comes to risk management and how to protect our doctors. He is nothing short of genius in our profession and is one of the few people ever to be respected on all sides of the political spectrum because he's always done what's good for the doctor. And he's a good friend. I consider him family. But most important, he's here to protect each and every one of you through education, and that's what he's going to do today. So I hope you'll welcome him and enjoy the information he's about to present on our behalf. So, Dr. Clum, all yours.
Thank you, Stu. Very, very kind of you. I appreciate it very much, and I appreciate the opportunity to be with you and Alan and our colleagues through ChiroSecure to chat a little bit about things that have gone on in the last 18 to 24 months, maybe a little bit longer, regarding the whole subject of cervical spine adjusting and vertebral artery issues. So let's get right to it and jump into it. Let me see if I can do my part here. And we should be in business momentarily. There we go.
Perfect. Looks great.
All right, great. Well, it is January 20th. 2 p.m. has already passed Eastern Time, and it's time to get down to business. Probably the most important thing that's happened in the past year or so has been the position paper that was released by the American Heart Association and the American Stroke Association. You can imagine that when rumblings were going on that this document was being prepared and that it was going to be published at some point down the road, but there were a lot of nervous people around the profession wondering what our colleagues from the Heart Association and what our colleagues from the Stroke Association were going to say about the concept of cervical artery dissection, particularly as it relates to cervical spine adjustment, or in their language, cervical spine manipulation. The good news is, and I'll cut to the chase and give you the good news, is the paper was remarkably positive for us. Now, there are things in there that I'll disagree with, and I'll point some of those out to you. But for the most part, they took a pretty factual approach to things. So I'd like to take a few minutes and just go through the first page or so in the overview of the paper that was published by the American Heart Association, American Stroke Association earlier this year. This came out in electronic form in the second quarter of the year and came out in print form in the third quarter of the year. So let's look at the purpose of the discussion. The purpose: cervical artery dissections, CDs, are among the most common causes of stroke in young and middle-aged adults. That's true. Statistically, 10 to 25% of all strokes that occur in that community of young and middle-aged people are the product of cervical artery dissection. That's simply a fact of anatomy and physiology and pathology. The aim of this scientific statement is to review the current state of evidence on the diagnosis and management of cervical dissection and their statistical association with cervical manipulative therapy. Obviously, you know, many people in the profession and beyond use the term cervical manipulative therapy in lieu of an adjustment. I prefer the word adjustment and so on. So they want to look at what's the diagnosis and management, the state of the evidence on diagnosis and management of these dissections as they relate statistically to cervical adjusting. And they go on to comment, in some forms of cervical manipulative therapy, a high or low amplitude thrust is applied to the cervical spine by a healthcare professional. This is the first of the important acknowledgments. It doesn't say chiropractor. The original or the first iteration of this article said chiropractor all over the place. It was pointed out to them that there are people that provide manipulative care to the spine that aren't chiropractors, and to suggest that this is a chiropractic specific situation was inappropriate, and they took that advice and counsel and they changed from chiropractor to healthcare professional. So let's look at their statement on results. Case control and other articles have suggested an epidemiological association between cervical dissection, particularly vertebral artery dissection, and chiropractic cervical manipulative therapy. Period. It is unclear whether this is due to lack of recognition of pre-existing cervical dissection in these patients or due to trauma caused by the cervical manipulative therapy. Let's go back and look at the first sentence. Case control and other articles suggest an epidemiological association between cervical dissection, particularly the vertebral artery, and CMT. That's what Cassidy said in 2008 in his publication in Spine, January 15th, 2008. But he also said, and the article doesn't say this, there was also the same statistical association, a similar statistical association found between visits to the primary care medical doctor as there was to the chiropractor. So while this statement is correct, that the articles, Case Control and other articles have suggested an epidemiological association between cervical dissection and CMT, it's also true to say that Case Control and other articles have suggested an epidemiological association between primary care visits and vertebral artery dissection. So we need to understand the broader context. We can be critical of this in this sentence, what it doesn't say, but what it does say is not incorrect, although it might be incomplete. We then look at the second sentence again. It's unclear. Very important acknowledgement. Very important on two levels. First, that it's unclear. 5 years ago, 10 years ago, this would have been a slam dunk. Of course it was the chiropractor. Of course it was the adjustment. Now the perspective is it's unclear. And that's the first acknowledgement. The second acknowledgement is that it's unclear and it's not understood whether it's the lack of recognition of a pre-existing dissection or due to the CMT. This is a huge acknowledgement because one of the things that has been talked about in the literature extensively, I have testified to in court on a number of occasions and have counseled chiropractors and have been part of the lectures I've given on this subject for over a decade, is that the current thinking is that the majority of these cases are dissections in progress that present for care to a chiropractor, to a medical doctor, to a physical therapist, to anybody, and that their circumstance is going to mature out and end up where it ends up, regardless of whether they saw the chiropractor, the medical doctor, or went for a Starbucks that day. So this is another huge point for us as practitioners. This does acknowledge that the situation that we're looking at may be a pre-existing condition. Well, I've heard a lot of chiropractors say, well, I don't need to worry about this problem because I practice NUCA, which is extremely low force. Or I don't have to worry about this because I practice activator. Or I don't have to worry about this because I don't use any rotation in my cervical adjustments. If we read this sentence carefully and understand it, it's saying to us, be very careful. This isn't about what happens in your office. It's about what walks through the door of your office. And the attention needs to be shifted now more toward the recognition of the pre-existing dissection in progress rather than the thinking that this was caused in the chiropractor's office. Now, we can't rule that latter component out. The research is not strong enough one way or the other to say we can say chiropractic care is not associated in any way with this. But what we can do is accept what this says. This is due to a lack of recognition of pre-existing cervical dissection in these patients. There is a significant portion of these patients that are in the process of dissection when they present for care, and they go on to have the sequelae of the dissection and the stroke, regardless of where they had gone that day. The conclusions of the American Heart Association, American Stroke Association. Although current biomechanical evidence is insufficient to establish the claim that CMT causes CD, clinical reports suggest that mechanical forces play a role in a considerable number of dissections. And most population control studies have found an association between CMT and VAD in young patients. Okay, so let's go back and dissect this sentence, or this group of sentences, no pun intended on that. Although current biomechanical evidence is insufficient to establish the claim that CMT causes dissection. That is a remarkable acknowledgement. No longer do we have to worry about or some bozo coming into court and saying the cervical spine adjustments cause this problem, period. Well, according to the Heart Association, they can't say that. According to the Stroke Association, they can't say that. And that's based upon the current biomechanical evidence. It's a very powerful and useful statement. It goes on to say, clinical reports suggest that mechanical forces play a role in a considerable number of dissections. Absolutely. We know that dissections follow circumstances, for example, automobile accidents. There was an article in 2005, I believe it was, by Beaudry and Spence out of Canada, and they looked at 80 cases of dissection over a 20-year period in their neurovascular practice, and they found that 78 of those cases were involved automobile accidents or industrial accidents that rose to the level of automobile accidents with the attendant mechanical forces. And then the statement goes on to say, most population control studies have found an association between CMT and VAD in young patients. Well, they have also found an association between CMT and primary care visits. So this statement, again, isn't wrong, it's incomplete. And I would be critical, and am critical, of this statement for that reason. So if you understand the broader and fuller context, this is less concerning than if you don't. Now, my comment on these areas. The statistical association between cervical dissection and CMT referred to here is found in the Cassidy study, no question about that. But so is an association between primary care visits and dissection. The association in Rothwell, which was the study that led to the Cassidy study, the Rothwell was the 2002 study, I believe, that appeared in the journal Stroke. Rothwell looked at X number of patients, had Y number of dissections within 7 days, 14 days of visiting a chiropractor, and did not look at it in the context of within 7 and 14 days of visiting a medical doctor, within 7 and 14 days of visiting an emergency room, within 7 and 14 days of having sex, within 7 and 14 days of having a cup of coffee. It was just out there. The Cassidy study took that Rothwell study one level further. They said, okay, we'll accept that you found a statistical association, but is there a similar, greater or lesser association with persons who visit medical doctors within a week of these events occurring? And in fact, Cassidy found in 2008, or published in 2008, that there was, in virtually every parameter, a greater incidence of dissection among patients who saw their primary care medical doctors within a week of the dissection rather than saying, or as compared to those that saw a chiropractor. This means that in those cases, it wasn't what was going on in the chiropractor's office that was contributing to the problem. It, again, is what walked through the door. Huge consideration that we need to be aware of and we need to understand completely. So let's look at these things again in review. What do we take from this joint position statement? Insufficient evidence to establish a claim that CMT causes CD. Big statement. It is unclear whether this, the epidemiological association, is due to a lack of recognition of a pre-existing dissection in these patients or due to trauma caused by CMT. And again, we talked about the idea that the association between primary medical care is there as well, countering some of that claim that was in those first few slides. So, based upon the American Heart Association, the American Stroke Association statements, and other literature, what can we say or what shouldn't we say? Let's look at what we shouldn't say first. The literature has shown no association between chiropractic cervical adjustments and CD. We can't say that. The literature has shown a statistical association between cervical spine adjustments and cervical dissection. It's a fact. It's also shown that same statistical relationship, or stronger, between this phenomenon and primary care medical visits. The American Heart Association, American Stroke Association has said chiropractic adjustments don't cause cervical dissection or can't cause cervical dissection. They didn't say that at all. They simply said there is insufficient evidence to support a cause statement. And the third thing we can't say is chiropractic adjustments don't cause cervical dissection and or stroke. They may well not. But based upon this literature and what we have to work with, we cannot definitively say that. We need to understand those and use those terms and use this information completely and make sure what we say about our interpretation is solid. Let's shift gears and leave the American Heart Association and Stroke Association behind, and let's look at an article from 2011 from Wouter Schwenk, who is at Sinai Hospital in Los Angeles. And Schwenk is probably one of the most prolific writers in medicine. He's a neurosurgeon, works predominantly in cerebrospinal fluid leaks and things of that nature, but does do a lot of vertebral artery and carotid artery work. And in a paper he published in 2011, an editorial piece, he said it is not the intimal layer, which is what we've been taught all along, but rather the media and the adventitia that are primarily affected in cervical artery dissection. These findings confirm the existence of an underlying systemic arteriopathy in patients with spontaneous cervical artery dissection, and they suggest that the outer layers are primarily involved in the causation of the intramural hematoma. Now, let's, again, take this one apart and look at it again. It's not the intima, but rather the media and the adventitia. Excuse me. And so we were taught all along, and I may have taught many of you, that the attention we needed to pay was to the tunica intima, and certainly it is important. But what Schwenk is saying is that in the cases of spontaneous cervical artery dissection, now, other parties looking at patients who have this problem after our care are going to say, well, that wasn't spontaneous, that was mechanical forces induced by the adjustment. But what they're talking about here is then that there is an underlying arteriopathy in patients with spontaneous cervical artery dissection. We know that patients with Marfan's disease, patients with Ehlers-Danlos syndrome, patients with autosomal dominant polycystic kidney disease, patients with fibromuscular hyperplasia, patients with extreme prolonged hypothyroidism, they all have a greater tendency than the normal or the average population to dissect. And we then go on and also look at the congenital variants, whether it's a Leydig factor 5 or some other type of congenital variant in the collagen that causes that patient to be at risk for cervical artery dissection. This, again, is another important statement that, again, it isn't necessarily the forces that are involved, it's the underlying strength of the tissue involved, and it's a pathology in the tissue, potentially, in many of these cases. An important acknowledgement from a very leading person in this world. The next paper I'd like to look at is from Walter Herzog, University of Alberta at Calgary. Guy has done wonderful work in the profession for years and years and years. And here in 2012, Herzog looked at vertebral artery strains during low amplitude cervical, high velocity, low amplitude cervical spine manipulation or cervical spine adjustments. The conclusion that Herzog and his colleagues came to is that vertebral artery strains obtained during spinal manipulative therapy are significantly smaller than those during diagnostic and range of motion testing. So let's think about that for a second. What they're saying is that in the process of giving an adjustment, we induce less force on that artery than is induced during a normal cervical range of motion study. And the strains are much smaller than the failure strains that are involved that would cause the artery to fail mechanically. Herzog and company conclude from this work that cervical spinal manipulative therapy performed by trained clinicians does not appear to place undue strain on the vertebral artery and thus does not seem to be a factor in vertebral basilar artery injuries. There's an important few statements in there that we need to look at. This is, first of all, excuse me, my screen is just, there we go. First consideration we need to look at is that this is assuming healthy vertebral arteries. Number two, this was a laboratory study. It was not in live patients, but it was in vertebral arteries that were dissected out and removed from cadavers. The strains were tested out. So there'll be some criticism regarding that this wasn't a real world, real time, real life situation. But those same types of strain testings for all sorts of tissues, whether those tissues are arterial tissues, whether those tissues are ligamentous tissues or muscular tissues, have been used throughout the history of healthcare to establish very important milestones in different disciplines. So it's important for us to keep in mind. So you may say, well, how could the strains be greater with a range of motion than with an adjustment? It has to do work equals force times time. The force involved in a cervical adjustment is very low, but the time is extremely low. In the consideration of the milliseconds that are involved in an adjustive thrust, it's generally in the range of 20 to 25 milliseconds, thousandths of a second, that the force is introduced into the artery. In comparison to a person who's being asked to go through a range of motion study, rotate the head to the right or to the left, and hold it, the time involved, the force times the time, creates far greater strain over time than the milliseconds of the adjustment. So it's important for us to keep that in mind. There's also been some literature over the years that has talked about patients experiencing dissections during the process of a range of motion examination. So it's not an unheard of concept. Another article I'd like to get to quickly is a very important one, a very exciting one from last year. And this has to do with changes in vertebral artery blood flow following various head positions and cervical spine manipulations. One of the criticisms over the years has been that we may not damage the artery with the adjustment, but we cause an abnormal blood flow, or normal pattern of blood flow, and if you're familiar with known as Bernoulli's principle, that we create an alteration in the blood flow that creates turbulence and greater pressure after the fact, and that damages the artery, or can damage the intima and set up a thrombogenic environment. Well, if we look at this paper by Quisnell, this is from a group at CMCC and involved people like Jay Triano and people that have been in this area of inquiry for a long time. They essentially took a series of real-time MRI studies that assessed blood flow before, during, and after an adjustment. and before, during, and after range of motions. And their conclusions, the findings, the side-to-side differences between ipsilateral and contralateral vertebral artery velocities was not significant for either velocities or flows throughout the conditions. So in the pre-adjustment, adjustment, post-adjustment, range of motion environment, there was not a significant change in the flows or the velocities before, during, or after. The conclusion, there were no significant changes in blood flow or velocity in the vertebral arteries of healthy male adults after various head positions or cervical spine manipulation. What's the most operative and most critical word in that? Healthy. The subjects that were involved in this were in their 20s, they were all healthy, and so on. So we have to be careful how far we can extrapolate this information, but this is very important, fundamental physiological activity that we haven't had a good handle on up until just recently with this work. Let's look at one of their concluding statements is that furthermore, only 2 trials have examined the effect of cervical manipulative therapy on human vertebral artery blood flow. Licht et al. Examined peak velocity in the vertebral artery after CSM on 20 students with biomechanical cervical spine dysfunction in a randomized controlled trial using Doppler ultrasound. Similar to the MRI data reported here, there was no significant change in peak velocity between the CSM group and the clinical control sample. In another randomized controlled trial, color-coded duplex sonography, Licht and colleagues found no change in vertebral artery blood flow with change in head position, CMT, or after CMT on blood flow. So when we think about this, this is again another important area. Herzog says we don't strain the artery enough to be able to adjust it, to be able to damage it. Shabink says that it's really not the intima that we need to be worried about. We need to think more about the media and the externa. And now Quisnell and Triano and company tell us in the process of an adjustment, we don't cause a change in Bernoulli's principle, or to invoke Bernoulli's principle, that we don't disrupt the blood flow, that the velocities stay the same, and the flow patterns stay the same before, during, and after an adjustment in the vertebral artery in particular. Getting close to my time limit here. I can hear my host getting nervous on the other end, so I'll take you into one area, emerging area of interest. And this may sound like a stretch for some of you, but there is a developing body of maybe 10 or 12 case studies on this subject, and it's worth being aware of because there's a simple way to avoid this problem. And the question is there a relationship between spinal adjusting, cervical spinal adjusting, or thoracic spinal adjusting for that matter, and cervical fluid leaks? And the cervical fluid leaks would yield a spontaneous intracranial hypotension, the type of headache that a patient has, for example, after they've had a spinal tap. Well, this whole headache process, or this spinal intracranial hypotension, was first described in 1938 in Germany. The imaging that we have today gives us the chance to measure these fluids in real time, see the changes much better, so on. We know this phenomenon occurs at a rate of about 1 per 50,000 patients. So this is twice as common as cervical spine, as vertebral artery dissection in the population. It was later described in a couple years later as being 1 in 20,000, which would make it 5 times more common. The average age is in 38 to 42, females 3 to 2 versus males, and it ranges from children to persons of old age. The key thing I can give you right here to take away from this whole process is when a patient presents with a positional headache, that is, when they're laying down, the headache goes away, they stand up, they get the headache back. That is the classic sign of a dural tear and a cerebrospinal fluid leak. When that patient presents to your office, my advice and counsel is refer them for a neurosurgical consideration and neurosurgical evaluation. Now, most commonly, this phenomenon develops secondary to lumbar puncture, myelography, spinal anesthesia, craniospinal surgery, etc. In other mechanical events, as simple as a Valsalva maneuver or coughing and sneezing have been on the record as inducing it. The first reference to this relative to chiropractic care came in 1997 with the proceedings by Mokra out of Mayo, and he didn't assert a causal relationship, He just simply said that one of the patients in his study had a previous finding of having visited a chiropractor. So relative to diagnosis, if the patient has a history of an invasive procedure, say a lumbar puncture, for example, if the headache is relieved by laying down, you want to get an MRI of the brain, and they're going to be looking for changes in the meninges and a thickening of the pachymeninges, the presence of subdural fluids, subdural hematomas, and a downward displacement of the cerebellar tonsils. In its most extreme form, this produces rupture and herniation of the brainstem and can be fatal in that environment. Thankfully, that's an extremely, extremely rare situation, but it does exist. And it can also be misdiagnosed as an Arnold-Chiari malformation number 1. CT myelography is helpful to find the site. Radionuclide cisternography, things we're not going to be involved in, but just for your background, will again help with site location. And lowered cerebrospinal fluid pressure is potentially diagnostic. So what's the takeaway today? The Heart Association folks have given us some stuff to work with. The other researchers along the way have helped us along. And this one area we want to keep in mind when a patient presents with a positional headache, they lay down, it's better. They stand up, it's worse. Be cautious. Hear these words in the back of your head. Send them out for a referral for a neurosurgical consult and go from there. Dr. Hoffman, Dr. Weinstein, thank you so much for the opportunity, and I hope it's been helpful to you and to our colleagues. Thank you, gentlemen.
Thanks, Dr. Clum. And I know that the people that are participating on this event will get lots of great information to utilize going forward. The reality is that most of our colleagues will never encounter a situation involving a stroke, which makes it hard to make real to people. But at the same time, there are a certain percentage of our doctors that will encounter a patient that winds up with a stroke and or a stroke claim. And the simple fact is that we get to deal with it. As much as the information that was presented today is terrific and helps us feel good about what we do from a scientific point of view, the public perception, just going on Google and looking at chiropractic and strokes, it's all over the place. We've talked about it before, we'll talk about it again. And having this kind of information and having somebody with the credibility that a Dr. Clum has, with the knowledge that he has and brings to the table, is something that we want you to know. You can feel secure, no pun intended, maybe it is intended, but you can feel secure in what you're doing, having someone like that on your side. And that's what we're all about, and that's what we want to continue to do. I'm working with Dr. Clum on other projects to make us even more bulletproof as a profession by utilizing research and facts and information that most other people, quite frankly, just don't have. So I want to thank him. It's always an honor to work with him and have him at our side. I just want you all to know how fortunate you are to have him be able to be available to us and therefore to you too. So thank you. And Alan, I want to just bring it back to you to do some housekeeping, and away we go.
Okay, well, just truly amazing stuff, that Dr. Clum. That was outrageous. I wanted to tell everyone that Dr. Clum, actually, to be on the show, is sitting in an airport doing this live event in an airport, and he and I were on the on a hangout last night preparing, like 8:30, 9 o'clock at night. I think he was in his hotel room, but he literally stepped up to the plate, and nothing stopped him from being here for ChiroSecure and Dr. Stu. And as I said, he is in the airport even right now. You're seeing on the screen right now the ChiroSecure page that you watch this on. Everyone who's on this, make sure, if you've not done so already, complete the form on the right side of the page so that you will get a copy of Dr. Clum's slides and the transcript of actually the live show, so sign up for that. Again, if you go up a little further on the page, what you're going to see is you could sign up for our concierge service right here on the right, and that will make sure that you get all the information, notes, transcripts of all our future presenters. We've just added Pat Gentempo, Bill Esteb, and Ted Corin to the lineup of people that are going to be coming on the ChiroSecure shows. And Dr. Stu is preparing a show that, to me, as a practitioner that's practiced for 30 years, is critically important, and that is, what is really the difference between occurrence and claims made? As far as I'm concerned, that's one of the most misunderstood things in malpractice, so you need to know that. So make sure that you sign up for the concierge service, or just sign up for the for Dr. Clum's information, either one. And if you've not done so already, make sure that you scroll up, click on the Quick Quotes link, fill out a Quick Quotes. You're going to be very pleasantly surprised about the rates of ChiroSecure if you're not already a ChiroSecure client. On behalf of myself, Dr. Alan Weinstein, Dr. Stu Hoffman, ChiroSecure, and a great presentation by Dr. Gerry Clum. We'll look forward to seeing you in another 30 days with another great ChiroSecure live event. Have a great day, everybody.